Thank you very much for that very kind invitation and introduction, and for the kind invitation to present at your conference. It's early hours in Boston. I am sorry that I can't be there in person, but I did want to deliver this presentation to you in person out of respect to you and for my many, many friends that I've worked with over the years from India. So it's a pleasure to be here. This is an interesting area of development in critical care, in particular, the use of massive amounts of data to try and develop predictive indices. And it builds on the work that you heard from Cedric around machine learning and the last presentation as well, which was fascinating and highlights the importance of bringing new workforce into our domains, in particular technicians, computer scientists, and engineers. I have disclosures in that I have been working in this space for the last 10 to 12 years and have developed some tools that enable us to capture and display time series data, high frequency time series data. But before we can start talking about the use of data for prediction, let's understand how we work. So we have a system that generates data simply by the way in which we manage our patients. We tend to know on admission what the diagnosis is. We risk adjust according to the disease and the procedure. We then predict what might happen in terms of discharge or what our expectations should be. We create environments and teams and workflow to deliver care. And then we overlay that with guidelines and protocols, early warning systems, quality metrics, and so forth to make sure we're delivering the care we need to provide. And that really encompasses the care of a patient. And that's the right thing to do. And then we rely on the electronic health record, in particular, imaging data, to help us with the various decisions we need to make. It's important to understand that the type of data that is generated in that type of circumstance, when we're relying on the electronic health record in particular, is that the data enables what I call prognostic enrichment. This is categorical transactional data that's included within the electronic health record and also within registries. The data can focus on a well-defined patient population, the outcomes of that patient population and the risk for an event perhaps within that population. But it's important to understand that it's comparative data. It enables us to share for sure, and we can communicate and trend risks. In other words, we can understand the what and the how, but there are limitations. So while we use it often for operational purposes and business performance within our systems, we use it for benchmarks and establishing outcomes, it doesn't allow us to determine cause. And often we rely on inference. For example, blood pressure falls. That fall in blood pressure is recorded as a categorical data point in the EMR. And then the response may be to give fluid. And the inference from that may be that, well, the patient was hypovolemic. And then you see the response. What we're not really getting is the actual decisions and the actual understanding of what the physiologic state is at that time. And that's because we have so many unmeasured variables that just do not make it to the electronic health record. And in particular, we do not capture variability in practice in our teams, in our systems, and we do not capture our decision-making along with the data. Now, here's a very good example of the value of this data, however, and this is from the Pediatric Cardiac Critical Care Consortium that really over the last decade has developed a very large data set of information, categorical information from many centers across the world. And I wrote this particular opinion piece based on an article that had appeared by the developers of PC4, where they noted that improvement in pediatric cardiac surgery outcomes was possible simply by being part of this inter-hospital collaboration, sharing data. And that membership to PC4 enabled a number of very important things. It enabled a reduction in post-operative mortality, in-hospital mortality, major complications, a reduction in length of stay, reduction in the duration of mechanical ventilation. So capturing that data, and it's a large amount of data, but it's categorical data that is captured within the registry, and simply being part of that registry and learning from within enabled improvements in the outcomes of patients. Incredibly important. Now remember that these are cardiac surgery outcomes. They're not critical care specific. It's a quality improvement collaborative where there is shared learning through an interactive series of dashboards for a range of clinical and operational metrics. As I said, it's comparative data, driving collaboration and research. And one of the aims is to minimize variability, but it does not get to causality, modifiable risk, or prediction. Now, I don't want to dismiss this at all. I think the prognostic value of data, such as derived from registries and the EMR, is incredibly important. And we should all contribute to these types of databases and use this type of data for prognostic enrichment. This was this same group that developed PC4 had a paper in 2019 where they looked for unmeasured patient factors after mortality after congenital heart surgery. And what they noted was not new, in that their age and prematurity status, underlying complexity of disease, preoperative clinical state, size of the patient, comorbidities, associated chromosomal abnormalities, all of these were risk factors for mortality. We've known this for some time. That's not new information. But what they did confirm, that there was a significant contribution to mortality of unmeasured patient factors that are just simply not captured within the registry or within the EMR for that matter. And system level factors in particular were not measured. How we make decisions, how we practice as a team and as an organization. Some of those factors are very important. So if we go back to the system of generating data, let's overlay a really critical piece to this. And that is, within the system we create, we make decisions. And our decisions bounce around. And these are decision nodes that I've shown here in this particular graphic. Now, some would say that that's just reflecting practice variability, that there's no need to have these variable decision making. Well, if it is practice variability, then using data from the EMR and registries for prognostic enrichment should allow consistent care, and it can be applied to a population of patients. However, I think that doesn't get to the heart of the problem that we manage in intensive care, and that is we manage biologic variability. We have to look at the individual. Individualized, precise care is what we should strive for. And to understand that biologic variability, we need to really move to our monitoring devices and the information that they are sending to us, and hopefully now we can capture. This type of data enables what I call predictive enrichment. It's based on biologic responses to illness and treatment. It's physiologic data, biomarkers, various omics that increasingly are becoming part of our decision-making, and allows us to first understand the physiologic state of a patient, the functional condition of a patient, and then the risk for an event within that state. Too often, we go straight to the latter. Too often, we try to predict the risks for a cardiac arrest, for infection, sepsis. What we need to do is make the step before that helps us understand the overall state in which the patient exists. That enables, as I said, individualized care. It enables us to get to causality and perhaps inference. But there's a problem here too. Vast amounts of data, captured, some of it structured, a lot of it unstructured. And it needs an architecture that enables us to use it and to feed into models that we can then use at the bedside. And that it's a problem because these translational data sets come with a variety of dictionaries and definitions and tables and labels. There is not a consistent pathway that we follow that enables us to standardize this. And this is driven by various vendors and monitoring companies and so forth. It's to their advantage. It's not to the patient's advantage. How much data are we dealing with? Well, this is Boston Children's Hospital. I took it just for the last 10 years, well, up to August 2020. And this is data collected on the T3 platform. It's digital data of all physiologic signals streaming from patients in the intensive care unit. It's data collected at 5-second intervals. The total hours of data through August 2020 was just under 10 million hours of data in 82,000 patients. I can say right now that it's about 120,000 patients, about 550,000 patient days, and nearly 13.5 million hours of data that's available to be, that's accessible for use, to model, and to use alongside the data that is collected within the electronic health record. It's the prognostic with the predictive data that enables us to really move our decision-making forward. How much do we collect in terms of waveforms in the predictive sense? Well, this is data taken out of sick kids, where I was fortunate to work for 8 years running the Department of Critical Care. And I call it a Niagara Falls of data occurring in the 42-bed intensive care unit there. Over Niagara Falls is 200,000 cubic feet per second of water. We're collecting data at around 200,000 bytes per second at sick kids. And I welcome you to look at our website here that gives a real-time ticker tape, if you like, or collection of the data. And so at least 2 weeks ago when I drew this screenshot, we had 4.7 trillion data points that have been collected over the last 5 years in nearly 9,000 patients. So you can see that there is a huge amount of data that's streaming, particularly when you start to collect second by second, waveform by waveform data. And of course, you need to add in all these other components to biologic variability. I mean, I'm talking about the phenotype, the functional status in critical care, but our next step is to take all of that data and say, well, let's add in the data from the EMR, from imaging, from social determinants of health, and then look at the metabolomic components, the proteomic biomarkers, the transcriptome, and then the genome. And when you start to add all of these together, you have a tapestry of data that will really allow us to get to prediction. Now, we are some ways from that. You heard from Cedric that less than 1% of machine learning and AI tools are implemented. I think that's very true, but it's going to rapidly accelerate. And as we do so, we will be stitching a tapestry together that brings and draws in all of these other components of data. Now, one of the problems in critical care is that this high frequency time series data is data in motion. It's important to understand where the bottlenecks occur, where the gaps in data occur, and what the quality of the data is. And so therefore, it's not simply a matter of plugging in to an HL7 feed and dumping the data somewhere. You need to have an architecture that allows you to understand the data that you're collecting, the quality of it, how it's formatted. In other words, develop an architecture that allows you to break down the bottleneck, break down the fact that this data is input to output bound. And at Sick Kids, Andrew Goodwin and colleagues were able to develop such a tool, which is a practical approach that allows us to collect all of that data, that 4.7 trillion data points, store it in a very efficient way, and now start to bring it forward for analysis at the rate of around 2 billion bytes per second. It's not real time yet, but boy, it's getting closer. And this is our next horizon, is to be able to make sure we have the architecture that enables us to display information at the bedside for us to use in our decision making. Now, I mentioned the aspect of population versus the individual, and I'm going to use one example here in a group of patients with transposition of the great arteries who were status post an arterial switch procedure at sick kids. In this first column of images is heart rate and blood pressure, systolic blood pressure, for the entire population. And you can see that for that population, we can see what the mean heart rate was and the ranges for each post-operative day. And that's great. It's nice to know where we expect for that population of patient, our ranges for these particular variables to exist. However, what we found, more importantly, I think, is that there is great individual variability. So within that same population, you can see these are different patients. And you can see that they vary, and they actually have much narrower range in which they keep their heart rate and their blood pressure in these examples. And this is, I think, an important point, that the individual care that we provide is important and not based solely on the population. This individual care is the predictive enrichments we get from physiologic data. The other population data enables the prognostic enrichment. We've also looked at different ways to analyze this data and predict risk. So I could go through a whole series of examples, but I wanted to take one from Jessica Nichols, recently published when she was working at Sick Kids with Steve Schwartz and colleagues, where they looked at 77 patients, 60 who had transposition, 17 with single ventricle. They looked at changes in their brain from pre-op MRI to post-op MRI. And we were trying to understand whether you could predict post-operative new injury as determined by MRI. And so if you look at the data, so no new injury is the red, new injury is blue, and these patients here are transposition, and these patients here are single ventricle. And if you look at that data, you can think, boy, there's nothing to decipher here. And that's correct. If you look at an individual signal, you cannot do a predictive analysis as to the risk for new brain injury. But if you take first principle component analysis, for instance, then we found that if you took it, that patients who had a higher blood pressure, patients who had a faster heart rate, and patients who had a lower oxygen saturation, that group, these blue dots, these were the patients that had new MRI injury. And so now we're seeing composite component analysis scores starting to give us a better and better prediction as to those patients at risk, and now targets for treatment. And it's not just one signal. In this case, there were 3 signals. And I'm certain that if we collected even more signals, we'd have a much clearer picture again of those patients at risk. Now, I talked about the physiologic state and the risk of an event within that state. And that work I've been doing for some years is to look at I think, a very important state, and that's the inadequate oxygen delivery. And we developed a Bayesian probability model of inadequate oxygen delivery, adding in all of these various signals. And this is based on normal and common physiologic understanding of oxygen delivery. There's nothing new or made up here. And we were able to demonstrate from newborns to 12 years of age that even with a minimum data set of 3 signals compared to the full data set, there was reasonable estimation of predicting a low oxygen delivery state. And that's the height of these red bars here. It's calculated every 5 seconds. Now, it's important to understand that this is not binary. This is not giving you a yes or no. Rather, it's taking all these figures, giving you an estimation of the adequacy of oxygen delivery, and it allows you to then incorporate it into your decision making. That's a very important thing to remember. This is not binary. This is not automated saying, yes, that is absolutely the case. But the higher the red, the more likely that the model is predicting for you or estimating for you that oxygen delivery is low. And I use this every day when I'm attending in the cardiac ICU. And I use it in another way, and this is to the risk of an event. So here's a situation that we published not so long ago. This is from 3 institutions: Boston Children's, Sick Kids, St. Louis, and DC Children's, so 4 institutions. And we looked at inadequate oxygen delivery, which is the height of these red columns here. But in particular, we looked at the exposure or the duration of exposure, so the dose of low output state. And we could calculate that the window or the dose of low output state was predictive of cardiac arrest. So now we're starting to look at physiologic signals in a much different way. And it's not just what's happening at this point in time. It's more than just the trend over an extended period of time. It's the duration, the dose of exposure that's important. And we've taken it one step further to look at it in another way. So one of the ways we behave in critical care is we have a physiologic state and we start drugs or mechanical or ventilate. You know, we're going to start a whole range of different drugs based on what the problem is we think we have to manage. That's normal. One of the problems we get into is actually coming off of that support over time. And we tend to stay on the vasoactive support longer than we need to. So we're using this type of inadequate oxygen delivery index as a means to help us wean from these drugs. And as we wean, if the IDO2 stays low, then we continue to wean. It allows us to get off of these drugs quicker and then accelerate the care of patients. So data is our asset. In critical care, make sure you've got the right connections, understand artifacts, understand that there are problems with labeling of the data, with dictionaries of the data, and the tables that are necessary. And understand that we have time series data, which is input and output bound. The models we develop need to be reliable, replicable, relevant, and represent the clinical situation that we're managing. And then finally, we must understand it as well to be usable. It must be explainable. We need to believe it so that we can incorporate it in our decision making. And then it needs to be actionable ultimately, so that we can use this information to change the way and improve the way. I shouldn't say change. I think improve our understanding and the decisions we make. So we're on this journey together. It's going to rapidly accelerate over the next 10 years. What is critical is that we all form partnerships and collaborations. The ability to have virtual remote teams, as you saw in the last presentation on virtual reality imaging, it's exactly the same with this type of physiologic data. We should have shared learning through shared data, and it should be at both the population and the individual level. And that's where we use data intelligently for us to develop decision trees and therefore improve the care of our patients. I want to thank you once again for the invitation. I'm sorry I'm not there in person, and I do appreciate your time. Thank you. There's my email if anybody would like to connect with me as well. Thank you for your attention.